So coming towards Sturge-Weber syndrome, left is the coronal graphic and it shows the extensive angiomatosis surrounding the affected gyri, prominent deep medullary collaterals, shunt venous blood to the deep system, enlarged ipsilateral choroid plexus, and atrophy of the right cerebral hemisphere. The coronal T1 contrast-enhanced MRI on the right side image shows extensive serpentine enhancement of the thickened pia, which is also called pial angiomatosis, and enlarged subarachnoid space over the right cerebral hemisphere. Severe right-sided hemiatrophy is evident. Left is the axial T1 contrast-enhanced MRI, and it shows the classic Sturge-Weber syndrome with atrophy of the right hemisphere, enlargement of the ipsilateral choroid plexus, and an extensive pial angioma, covering almost the entire surface of the hemisphere. Right is the more cephalid T1 contrast-enhanced scan in the same patient, and it shows similar findings. On this image, a cluster of dilated vessels in the subarachnoid space is also visible. Some more cases of Sturge-Weber syndrome. Left is the axial flare MRI image in a 25-year-old female with a left-sided port wine stain, and it shows the hyperintensity in the left parieto-occipital sulci, which is also called the IV sign. The right is the axial T1 contrast-enhanced fat-suppressed MR sequence in the same patient, and it shows the extensive pial angioma. Note the enlargement of the ipsilateral choroid plexus. Left is the more cephalid T1 contrast-enhanced fat-suppressed MRI sequence in the same patient, and it shows the enhancing pial angioma, which is filling the enlarged sulci. Also note the enlarged collateral medullary white matter veins that are draining the affected brain. Right is the T1 contrast-enhanced fat-suppressed MRI sequence in the same patient, and it shows the enlarged convexity sulci are entirely filled with the intensely enhancing pial angioma. Left is the axial T2 star SWI, a MIP image in the same patient, and it shows the enlarged tortuous medullary white matter veins that drain centrally into the enlarged subependymal veins. Right is the lateral DSA image, venous phase of the left internal carotid angiogram, performed as part of a WADA test for language localization, and it shows a paucity of normal cortical veins with a prolonged vascular blush caused by the contrast stasis in the multiple enlarged medullary veins. Left is the axial non-enhanced CT scan in a 33-year-old male with long-standing seizures history, and it shows a calcified gyriform mass in the high right posterior parietal lobe. Right is the axial flare in the same patient, and it shows that the cortical mass is hyperintense. Left is the T2 star GRI sequence, and it shows blooming of the gyriform calcification and cortex. Right is the axial T1 contrast-enhanced fat-suppressed MRI, and it shows the serpentine gyriform enhancement of the mass. There were no other lesions seen and no cutaneous abnormalities. This is a case of presumed, not surgically proven, meningioangiomatosis. Left is the coronal T2 weighted MRI of a classic basal cell nevus syndrome. So now we are going to describe the imaging findings of the basal cell nevus syndrome. So these are the cases of basal cell nevus syndrome. The T2 weighted MRI of a classic basal cell nevus syndrome, and it shows a large unilocular T2 hyperintense cyst which is arising from the left maxillary alveolar ridge. This cyst is bulging into the maxillary sinus, displacing the floor of the sinus and secretions superiorly. Distinguishing a sinus mucus retention cyst from an alveolar ridge or dental cyst is best done on coronal images. Right is the coronal T1 weighted MRI, and it shows a T1 hypointense cystic mass. The floor of the sinus is less well characterized than on the coronal T2 image. So left is the axial non-enhanced CT scan of a 16-year-old with the basal cell nevus syndrome, and it reveals the extensive lamellar calcifications of the falx cerebri and the tentorium cerebelli. A defect is evident in the right temporal lobe secondary to the resection of a convexity meningioma. Axial bone CT demonstrates a well-defined expansile lesion in the angle of the mandible on the left. At surgery, the pathologic examination showed the lesion to be an odontogenic keratocyst. Left is the axial T2 weighted MRI in a 3-year-old boy, and it shows a well-defined T2 hypointense mass in the posterior right cerebellar hemisphere. Only slight edema surrounds the mass, which was proven to be a medulloblastoma at pathology. On the right is the axial non-enhanced CT scan in the same patient, which was obtained preoperatively, and it reveals 2 small dural-based calcifications. Such calcifications are not normal in a child of this age, and they definitely should prompt a workup for basal cell nevus syndrome. And this syndrome was confirmed with a molecular genetic test. Left is the axial T1 contrast-enhanced fat-suppressed MRI sequence in a 6-year-old child with the known case of basal cell nevus syndrome, and it shows a small cystic mass in the anterior left maxillary ridge, consistent with a keratocystic or odontogenic tumor. This cyst has a thin, faintly enhancing rim, and an unerupted tooth medially is also noted. The MRI was performed as a screening test for medulloblastoma. Right is the axial T2 weighted fat-suppressed MRI in the same patient, and it shows the moderate hyperintensity of the lesion contents and a hyperintense unerupted tooth medial to the lesion. Left is the coronal T2 weighted fat-suppressed MRI, and it reveals a T2 hyperintense mass filling the left nasal cavity and extending into the ethmoid air cells. This 19-year-old kid with basal cell nevus syndrome was radiated for medulloblastoma and developed a radiation-induced rhabdomyosarcoma. Right is the coronal T1 weighted contrast-enhanced fat-suppressed MRI sequence, and it shows the moderate enhancement of the nasal mass, which infiltrates the dura above the roof of the ethmoid air cells. A Fox meningioma is also noted. So left is the axial FLAIR MRI in an 18-year-old male with family history of hereditary hemorrhagic telangiectasia. It was obtained as part of routine screening, and a small left medial frontal hyperintensity with associated flow voids is noted. Right is the axial T1 contrast-enhanced MRI in the same patient, and it shows that the lesion is enhancing intensely. Left is the coronal T1 contrast-enhanced scan in the same patient, and it shows the lesion has a somewhat speckled appearance. The right is the lateral view of the left internal carotid BSA, which was obtained in the same patient, and it shows a small arteriovenous malformation, that is AVM nidus, with an early draining vein. Genetic profiling showed the ENG mutation. So some more cases of hereditary hemorrhagic telangiectasia. Left is the axial T1 contrast-enhanced fat-suppressed MRI scan, but it was done on 3 Tesla. It was screening MRI, and it was obtained in this 11-year-old female with a family history of hereditary hemorrhagic telangiectasia. And it shows 2 tiny fluffy foci of enhancement, which are very much consistent with capillary vascular malformations, which are also sometimes called micro-AVMs. Right is the more cephalid T1 contrast-enhanced fat-suppressed scan in the same patient, and it shows 2 additional micro-AVMs. Sporadic multiple AVMs are uncommon. At least 50% of such cases are eventually proven to have hereditary hemorrhagic telangiectasia, which is usually type 1. Left is the axial T2 star XRAY MRI of a child with diagnosed hereditary hemorrhagic telangiectasia, and it shows hypointensity in the left parieto-occipital region due to the susceptibility effects of a pial telangiectasia. Similar lesions were seen in the right cerebellum and left middle temporal sulci, which are not shown. Right is the axial T1 contrast-enhanced SPGR MRI in a child with diagnosed case of hereditary hemorrhagic telangiectasia, and it shows a left cerebellar DVA, which is draining into a posterior pial vein. Although not specific, DVA, that is developmental venous anomalies. So although DVAs are more common in hereditary hemorrhagic telangiectasia than in the general population. Although they're not specific, but they are very much common in hereditary hemorrhagic telangiectasia. Left is the axial T2 weighted MRI in a 16-year-old female with hereditary hemorrhagic telangiectasia type 1 who had a negative screening MRI at age 9 and is now showing a small, round and linear flow void in the left frontal lobe. Right is the axial CTA image, that is CT angiography image, was obtained in the same patient, and it shows a well delineated tubular structure suggesting a vascular malformation. A pile arteriovenous fistula was found and resected at surgery. Arteriovenous fistulas are the least common of the three major types of cerebral vascular malformations that are associated with hereditary hemorrhagic telangiectasia.